Good evening, all. I'm sure we've all had a good day, and I say thank you for this highly educating program we've been having on OSN. So I'm Dr. Balogun from LASUT. I'll be talking about eyelid trauma and the principles of management. And this topic really is very important in our day-to-day practice. We see a lot of patients coming in with eyelid injury. An eyelid injury, we all know, can be vision threatening. So our goal really today is to be able to, sorry a minute. So today our learning goal really is to be able to, as individuals, ophthalmologists, general practitioners, whatever our specialty and subspecialties are, to be able to recognize and adequately evaluate patients coming in with eyelid and canalicular trauma. Like I said, these are injuries that are potentially vision threatening. So we must also know where to look for when we have a patient coming to us with eyelid injury. We should be able to provide first aid measures for these patients, especially if we are not in oculoplastics where you have complex cases coming in. And it's also important that we are able to efficiently manage simple eyelid injuries. We all need to know, and also to prevent, complications. While we manage these patients, there are needs for referral. We must also be able to recognize this. And we should put at the back of our minds that eyelid injuries and lacrimal system injuries play a very important role in the quality of life of the patients. As we go along, we'll come to appreciate why this is so. Sorry, this is taking up space. Yes, thank you. So I'll start by letting us talk about the visual implication, the functional implication, aesthetics, and quality of life of the patient, like I already said. I'll talk a bit about the relevant anatomy of the eyelid and the lacrimal system. Give a bit of information on the etiopathogenesis of these injuries, a little information on the epidemiology, because I'm sure Professor Adepoju will go to town with that. We'll talk about the clinical features and management generally. So these injuries, eyelid injuries, like I said, they could involve the entire eyelid, they could involve the margin, they could involve the canalicular, they could also involve the canthal area. Some of these injuries can also involve tissue loss, and there could also be associated globe and orbital involvement in these injuries, especially in those patients who have midfacial injuries. So let's get clear the normal anatomical positions of the eyelids. The upper eyelid normally should be 2 millimeters above the superior limbus. The lower eyelid should be at the level of the lower limbus. And it's very important that a patient achieves these two anatomical positions, because that way the patient will be able to maximally close the eyelids at sleep. And that is very important, because if the eyelids are not properly closed at sleep, we all know there's the risk of exposure keratopathy and the subsequent complications. It's also important that the eyelids are mobile, because they play functional roles, they have physiological roles. Their mobility helps to keep the corneal surface wetted. So based on that, I will come on to the anatomy itself of the eyelid. The eyelid, we know, is a thin movable fold of skin, the thinnest in the body, and is divided for anatomical purposes into anterior lamella, which consists of the skin and the orbicularis oculi muscle, and then the posterior lamella, which consists of the tarsal plate and the conjunctiva behind it. The eyelid has about 7 layers. That's the skin, the subcutaneous areolar tissue. All of these really come to form the very thin layer. The orbicularis oculi muscle functions to close the eyelids. The submucosal muscular areolar tissue is also a very thin layer. And then you have the layer of striated muscle, that's the Mullens muscle, which lies beneath the levator palpebral superioris. And then you have the palpebral conjunctiva. The levator palpebral superioris actually has its fibers fan out. Sorry. It has its fibers fanning out through the orbicularis oculi muscles, and that goes to attach to the skin to form the. I'm sorry, I'm just looking for my cursor all over. So those are the fibers of the orbicularis oculi muscle. They come as a part of from the muscle, and then they pass through the orbicularis oculi muscle into the skin, and here you have the lid crease formed. The muscle is also important. It helps to keep the eyes closed. The septum, orbital septum, runs from the orbital rim to the tarsal plate, and also the levator tendon inserts above and anterior to the tarsal plate. The meibomian glands are very important. They're in the tarsal plate and with their secretions. But for the purposes of this talk, the important thing to know is that the eyelid is divided into the lamella, anterior lamella, posterior lamella. And then it's important for us to recognize that here we have the mucocutaneous junction, the gray line. Here we have the orifices of the meibomian gland. And then here we have the lashes. These three layers are regions. Yes, let me put them as these three important anatomical structures are very important when it comes to suturing the eyelid, because they are an important anatomical landmarks that tells you this is where you should pass your sutures through. So that's the eyelid, very highly vascularized, gets its blood supply from ophthalmic, division of the internal carotid, and then the corresponding venous drainage. So just as the eyelid is highly vascularized, trauma to the eyelid can actually come up with very severe ecchymosis, edema, because of the good vascular supply. On the other hand, it's also advantageous because that helps the eyelid to heal to heal soon after injury. The nerve supply to the eyelid from the ophthalmic division, and then you have this, the supraorbital, the supratrochlear, the infratrochlear. It's important to have this because when it comes to anesthetizing the eyelid in local procedures, these are important landmarks. And here you have the nerve supply, oculomotor, cervical, sympathetic to the medullary, facial nerve to the orbicularis oculi muscles. So when the the eyelid has important physiological roles, and the most important of all, it lies anterior to the globe, and by virtue of its position, here in this position, there's protection. It helps to protect the eyeball. Blink also ensures even spread of tear film, helps drainage, helps corneal wetting, and so that way it helps to keep the surface of the globe healthy. It tracks dust, it helps to wash off foreign bodies as well. So in clinical practice, what are the etiological causes of eyelid injuries? Most often our patients come with mechanical injuries. Injuries either blunt injury or penetrating injury, injury during sports, injury from occupation, injuries due to road traffic accidents, assaults. These are the common causes of mechanical injuries. You can also have thermal injuries from fire accidents, from burns, from from fire accidents and scalds. And we can have eyelid injuries as well from chemical injuries, acid burns, alkali burns. Electrical injuries are also a source of eyelid injury. You can also have injuries from radiation injury. For example, patients who are being irradiated for tumor management. But today I'm going to focus mainly on mechanical injuries. We all know how to manage most of these other injuries in the acute phase. Management usually will be medical management. So I'll focus mainly on mechanical injuries, which will, which will require surgical intervention. So what are the pathological changes that we have in the eyelid following trauma? It's basically the same as we have in any trauma. Inflammation is the main thing that takes place. And following inflammation, the body wants to heal the injured tissues. So there could be fibrosis, which we'll describe as cicatrization. And when we have this, we do not manage our patients properly, then there could be complications of the eyelid. There could be contracture, there could be shortening of the eyelids. And if the anterior lamella is involved in this fibrotic process, then we can have cicatricial entropion. That's the outward turning of the eyelid. Sorry, inward turning of the eyelid, because now it's the anterior lamella that is shortening. Whereas if we have a posterior lamellar shortening, then the patient will have entropion. So it's important that we recognize our patients' predicaments much earlier, very early, and manage appropriately. So in looking at eye injuries for purposes of management and for us to keep in mind, how do I go about caring for this patient? If you have in mind blunt eye injuries, those are injuries like, as the name implies, from blunt objects. And penetrating eye injury are injuries that actually associated with laceration. There's a break in the eyelid. So these injuries can be margin involving, like I said, the eyelid margin, or they could be margin sparing. We could also have associated canalicular injuries, or let me say proximal lacrimal system injuries. The canalicular could be involved, the punctum could be involved, the yes, canalicular and punctum, those are the proximal drainage system. We could have the canthus, canthal area also being involved, in which case the tendon, which is very important for stability of the eyelid, medial canthal tendon, lateral canthal tendon, could be involved, and that would then mean that that patient can come with some amount of laxity of the eyelid. Like I said earlier, eyelid injuries are not always in isolation. You can have these injuries associated with globe injuries. You can also have orbital and periorbital involvement in these patients. So in clinical presentation, our patients will see them day to day. They will come in a variety of ways. And most of the time, no two patients will come to you with exactly the same kind of injury. So we need to be well versed in managing and identifying these cases. So my first case, the panel to the left, is this young woman who has blunt eye injury. And we can see the eyelid, there is ecchymosis of the eyelid. The eye is also involved in the injury. But what I really want us to know is the red arrow showing a small area there. When we have injuries like that, especially from the history, depending on the etiology of the injury, we should watch out for entry point for foreign bodies, because this could be an entry point for foreign bodies, and the foreign body could just go. Even pellets can just get in the eye like that or in the orbit, and we may not notice it because the entry point is usually small and will soon actually be closed by reactionary edema. So we must note that. The panel to the left is a case of blunt eye injury again, ecchymosis. For these patients, apart from the injury, she's left with ptosis. As time goes on, we'll follow up these patients to see if was this ptosis just because of trauma, inflammation, or is there more damage beyond what we have in our hands at the time of presentation. This is another case of a young man, knife stab injury, penetrating assault injury. And we can see from this picture the extent of damage to the patient. There's so much damage, extensive laceration involving the nose bridge, the medial canthal area, the upper lid, lower lid, and you can see from this injury that there's prolapse of the tarsal plate. Apart from that, the proximal lacrimal drainage system, the punctum, is definitely involved in this injury. Because it's a stab injury, sharp object, we should also suspect that could this patient have medial orbital floor fracture, medial orbital wall fracture by the position of this injury. Is it likely that this patient can have globe rupture because the sharp object may have penetrated the globe? This patient can eventually develop orbital cellulitis if care is not taken from infection. And this patient may even go blind from uh, the injury itself. We never know how far this knife can go. It can even go as far as severing the optic nerve, causing optic nerve avulsion injury. So all of this we must have in mind. Watch out for them and do the necessary investigations to help us to arrive at a good conclusion and then properly manage this patient. There are also injuries where you can have tissue loss. Sorry, I think I've did something. I'll go back to that. So this is another case of blunter injury with globe involvement. The panel to my left, that's a young man there. This time around, you can see the injuries. Neither it's an open injury, but it's just the two of them. They presenting that what looks like crush injury. Apart from that, this patient also have corneal laceration with uveal prolapse. So this is a very, very bad injury. And there are cases as well in which you can have tissue loss. This is another kind of injury. And here you see that this lady who was due to assault has quite a big tissue loss. That whole area is deficient. So if this lady attempts to close the eye, definitely about half of the globe will be exposed, exposure keratopathy. So in these patients, what we actually do, if they have such amount of tissue loss, more than 60% tissue loss, we then have to borrow from the lower lid, in this case, to help to fix the upper lid, which we describe as the Cutler-Beard procedure. And this has to be done early enough because we don't want this patient to lose vision. Risk of exposure keratopathy, corneal laceration, all of these are there. Another common etiology for this kind of injury is dog bites. But luckily in our environment, we don't have so much of dog bites around here. It's not to the eyelid. Traumatic ptosis, I've already spoken about. This is another case. And then you can have injury, like I said earlier, involving the canalicular area. This patient has canalicular laceration together with the eyelid injury. So there's a lot of edema. This patient presents in the acute phase. Eyelid injuries can also be associated with globe rupture. Here you have a case who has multiple eyelid laceration. That's the laceration there. That's another laceration there. And that's the globe rupture. And see there's extensive uveal prolapse. This definitely has a very poor prognosis for vision, because even if you fix the eyelid, a lot of damage has been done to the globe itself. This is a young boy with avulsion injury to the lower eyelid. And children are susceptible to this kind of injury, particularly in our environment here, where the eyelid can get hooked with the hook of the dress or the door spring. I've seen cases of children who come in trying to open the mosquito net door, and then it comes back like that and it springs on them and tears off the eyelid. Even the door handle is also a culprit. So that's another risk factor for this kind of injury in children. We're able to manage this child, we're able to fix the lower eyelid laceration, this child. So in management of these patients, for example, the one who has the canalicular laceration, it's important if we get these patients early enough, we can then, it's a procedure that requires good lighting, you want adequate lighting, you want to use the operating microscope to try and see if you can identify the canaliculi and anastomose it, as well as stent the lacrimal drainage system, so that the patient does not come back to us later on with epiphoria. So this is what we do. We try to identify that's the punctum, the vertical part of the canaliculus, and then this is the horizontal part. So we try to pass your fluid through the patent punctum, for example, in this case, the upper eyelid, and you watch out for the reflux of this fluid. So where you get that, then you are able to anastomose, and that's your stent in place to try to fix that. And you also fix the laceration of the associated laceration. So what are the surgical principles of repairing an eyelid injury? Most importantly, we want to see as best as we can to restore the anatomy and physiological function of the eyelid, which I already mentioned. And you also want to give this patient the beautiful aesthetic look that everybody likes, and that way you also improve the quality of life of these patients. Because when the eyelid has any malformation, that's the part of the body that everybody looks at initially. That can mean a lot to the patient, can reduce their self-esteem. You may not be able to get a job and things like that. And we also aim at prompt repair and healing by primary intention, because that way scarring will be reduced and functionality will be better restored. Layer by layer tissue apposition and suturing, that's basic principle for us. We want to make sure that conjunctiva to conjunctiva, tarsal plate to tarsal plate, muscle to muscle, skin to skin. And that's important because in general practice, we find out that most of our patients, when they get to wherever they're taking their first treatment, the eyelid is just sutured anyhow. They come back to us much later and it becomes a problem. So if we are all able to do this procedure properly, it's then our duty to teach whoever we come across as doctors to be able to do this suturing, especially the medical, the general physicians, because that's where the patients get to first. Another key factor is maintaining the eyelid margin alignment. Very important, because the eyelid margin is what tells us, is what shows our work later on. If we do not appose properly, that patient is going to have notching, is going to have some kind of distortion. Even the wound will break down, and nobody, your patient won't be happy if you have to repeatedly go to theater just to fix the eyelid. You need to replace tissue loss when there's full thickness skin grafts. It's important, and you can achieve this. Sorry, when there's full thickness tissue loss, it's important, and you can achieve this using either the skin graft, you can use mucous membrane graft, you can use cartilage, you can also repair with flaps. It's important when you have to graft the tissue that will take more than 30% donor tissue, that's 30% higher than what the recipient site will need. This way we'll be able to compensate for contracture cicatrization later on. And then at surgery, we also want to make sure that you are putting your graft on a hematoma-free bed. Otherwise, you can lose your graft. Graft stability is also very important. When you finished your procedure, you want to use bolster, for example, to help to sit the graft properly so that the graft gets vascularized early enough. So for eyelid repair, it's divided into segments. Normally, we divide the eyelid into segments 30%, or let's say 33%. So depending on how much tissue injury, laceration, for example, the patient has, 30%, if the area of the injury is less than 30%, you can do less than 30% tissue loss, I'm sorry. You can do direct closure, because that will not stretch the eyelid beyond what it can take. So that way, you just get your sutures, you suture layer by layer. However, if you have tissue loss of 30 to 60%, you will suture the wound, but before you do that, you have to do lateral cantotomy and cantolysis. This helps to mobilize the eyelid so that your primary wound will close comfortably without tension, because tension on that wound can actually mean the eyelid pressing on the eyeball. That can raise the intraocular pressure, and you don't want that. If there's also too much tension, the wound can break down. Too much tension, you can have so much fibrosis, so much scarring later on. However, if you have more than 60% tissue loss, that's a big one, you have to use a flap. For example, the Cutler-Beard flap that I talked about earlier. You borrow from the, if this loss is in the upper lid, then you are borrowing from the lower lid to fit the upper lid. Later on, you separate the upper lid again from the lower lid. So this way, you have succeeded in helping the upper lid to restore its anatomy and function. You can also do the tensile semicircular flap, in which case you make a semicircular incision and it helps to mobilize the eyelid further. Or you can take a mustard flap, but then that means that you have very huge tissue loss, and that's also an extensive procedure. So this is what happens when we are trying to repair our marginal wounds. And this picture is illustrating to us what I said earlier on. That's the lash line. You can see there's a suture there. Those are the orifices of the meibomian gland. You can see another suture passing through that. And that's the gray line, another suture passing through that. So you take your suture about 1 millimeter, 1 to 2 millimeters away from the margin, that's the wound, from the margin of the wound, and then you go straight down and cross over to the other side, equivalent distance within the tissues, and you come out on the opposite side. So you do that for all these three important anatomical positions, and that way you would have ensured that tissues are properly matched and properly opposed to each other. When we do that, you tie the sutures one by one, and you leave them long, so that later on when you close the other part of the, when you close the inner layers of this wound, you then use that suture to tie down the sutures along the lid margin so that they don't roll back into the eye. Or the alternative, you can also make these sutures in such a way that they are they are buried so that they don't roll back to rub on the cornea. While we are doing this, it's important that we include the tarsal plates, like I said. We must avoid suture penetration of the conjunctiva, because the conjunctiva lies next, palpebral conjunctiva lies next to the ocular surface, specifically the cornea, and you don't want your suture abrading the cornea. The marginal sutures also, when you finish, you tie them sutures, and you want this to form like a tent, a small tent, that's like a small cone-shaped area. so that when the tissues heal and there is healing, there is fibrosis, they will come to lie on the level surface. Because if you don't do that with contracture, you have notching, and that's also not acceptable. So this is still talking about the suturing layer by layer. Our choice of sutures too is important. We want to use absorbable sutures, but for the tissues, for the inner tissues, because you can't go back to open your wound to take out those sutures. And Vicryl is very good for that. 6-0 Vicryl, 5-0 Vicryl will do that for you. Make sure that you give your tissues the appropriate tensile strength, not too loose, not too tight. So in injuries with 30 to 60% loss that I mentioned earlier, this is the surgical procedure that you do. So you do not do direct closure alone. There will be tension on that one, like I said earlier. That's why I put that X as wrong, not alone. So what you do, this is your wound, shaped in a pentagonal fashion, because you also have to shape your wound properly to get good apposition. And then you come to the lateral canthal area, because now you want to mobilize tissues medially. So that's your area of interest here is this tendon, that's the lateral canthal tendon. And you want to do cantholisis so that you release this inferior branch of the tendon. When you do that, your eyelid will move freely, and then you'll be able to mobilize to close this wound, and then you also close your incision here later on. Sorry, at the same sitting. So for 30 to 60% loss, lateral canthectomy, lateral cantholysis is very, very important. When you need to do a tissue graft, there are also principles for selecting your graft donor sites. You want to choose a graft that has the same texture, the same color, and also you will have to put in mind tissue availability. Sometimes you want to take a graft, but the tissue there too is not healthy. So we have options where you can take graft for eyelid repair. Like I said, graft should be 30% broader than the recipient site. You want to handle your graft very gently. You want to denude fat completely off the graft. Anything yellow that you see on the graft, you want to take off that fat. Because if you don't do that, your graft will not get vascularized early enough. And you want to ensure that your graft bed is hematoma free. If you have a large graft, you can buttonhole so that any bleeding will drain out. Graft stabilization, very important with your booster. You just apply like rolled up gauze tied onto the surface of that graft so that it sits nicely. So these are the areas where you can get the full thickness graft from. First is the contralateral upper eyelid, for example. But this is not possible in young people who don't have any amount of laxity of eyelid skin. So we can actually use this procedure in the elderly. Another position where you can get a graft from is the supraclavicular area. That's another area where you have good skin, similar to the color and texture of the eyelid skin. You can also take your graft from the post-auricular area. That's a hidden area, just like the supraclavicular area is hidden. So when you're taking your graft, you suture, your patient goes, is happy uh, with the surgery because you have not added another aesthetic defect to the patient. You can also take a graft from the Pre-auricular area, labeled number 4 here, to graft your tissue. For example, you may have patients who have burns, and if the burns affect all other places, and that's the area that you have left, you can take your graft from there. That's the pre-auricular area. And then you can also take your graft from the inner surface of the upper arm, the hair-free area. So, following our surgery, it's important. There are some of these patients that we have to treat conservatively following eye injuries. For example, those who have blunt eye injuries, they don't need surgery. So you put them on antibiotics, oral antibiotics. We also use topical antibiotics for prophylaxis, or if they have any eye associated eye injury. And then you want to put them on anti-inflammatory drugs to stem down inflammation. Cold compress is very useful for these patients because that helps to keep the temperature down, reduce inflammatory response, and that also promotes healing. And in a way, when all this is going on, infection too, it's likely to be reduced. I'm not saying the cold compress reduces infection, but when inflammation is reduced, the risk of your wound infection too is also reduced. And then for patients who have injury to the globe, they should be managed appropriately. Injury to the orbit, they should be managed appropriately. Patients who have other facial injuries would be co-managed with the maxillofacial unit. So the importance of multidisciplinary approach in managing our patients with eyelid injury it remains. We shouldn't just leave the patients and not invite the other people. And again, sometimes it's not intentional. These patients have more severe injury, so they come to us late. Some of them actually have life-threatening injury that needs to be treated first. So that multidisciplinary collaboration is very important, because if the other units know that you are forever willing to see those patients early, they will also call you in on time. So we must work together with these other units. So now there are situations where we need to do investigations in these patients as well. For example, if we suspect globe involvement, orbital involvement, we need to do investigations to CT scan, for example, will be very useful when we have globe involvement in these patients. So, and orbital involvement as well. So these are the complications we want to avoid in our patients who have eyelid injuries. And these are the situations that make life unbearable for these patients. These are the situations that impact negatively on their quality of life. Can imagine this situation. This person can't go to work, can't go to school, can't socialize. The same in this patient who has the tarsal eversion with conjunctival keratinization. So this kind of patient, for example, apart from having this eyelid repaired, we must also take proper care of the cornea, because with this amount of keratinization, if you fix this eye and then you stand a risk of having corneal abrasion. So in this kind of patients, you want to soften the keratinization first. You advise the patient to use ointment over a period of time, and then when you do the surgery, it's better to protect the cornea with bandage contact lens at the initial stage. This patient actually had electrical injury. She falling electric cable hits the patient, and this is what we are left with. So this is an example of a case who needed treatment in another unit. before the ophthalmologist will see. So these patients actually get to us with complications. She also had cataract. This is another patient who has extensive upper lid, lower lid injury, abortion injury. And unfortunately, this patient didn't present on time. So the blind eye, you can see that the cornea is completely opaque, is vascularized. So it's important that we treat our patients early.
You want to clean it, so it will clean tomorrow.
The patients, if we all take time to educate our colleagues as well as to why patients should be referred early, these are reasons for that. So having said all this, a post-operative care of these patients is also very important because after surgery, some of these patients will still come back with complications. We must be available,
100
sort out the
fún nínú owó ìwé the same time náà ni mo san school fees nígbà yẹn. Receipt ẹ wà nínú ẹ̀ check your phone.
Sorry, there's so much.
I scan it and send it to you.
Please, can we mute our microphones? Thank you so much. So the role of antibiotics, anti-inflammatory, and follow-up care of these patients are very important because some of these patients can come back to us later, like I said, entropion, ectropion, epiphora. We have to educate those that are likely to have it because some of them actually come when we cannot avoid these situations anymore. So our take-home message is that our emergency room doctors need to collaborate with them, teach them these little procedures, eyelid repairs. The same thing with our general practice physicians friends. We as ophthalmologists, we need to be very well versed in the management of eyelid injuries. Early surgery is advocated, multidisciplinary approach, very necessary. Counseling and follow-up is also very necessary in caring for our patients. These are my references, and I say sincere gratitude for being invited to do this talk. I'm also grateful to my Oculoplastic Society for sending me to represent them. Thank you all for listening.